Hello and Ya Alimadet. Welcome to the session Menopause Treatment Options, a part of the Your Health is Your Wealth series. My name is Mahina Wadia, and I'm a registered nurse specialized in hemodialysis and specialty pharma infusions, practicing in Calgary, Alberta. I serve as a co-lead for programming on the National Health Promotion Portfolio of Aga Khan Health Board for Canada, and I will be moderating today's webinar. The objective of today's session is to learn how to manage menopausal symptoms with the different treatment options available. We invite everyone to sit back and relax while we have a candid conversation with our panel about navigating menopause. Before we continue, we would like to thank the volunteers who have helped us develop this webinar. I'd like to start with a land acknowledgement, where we acknowledge the Indigenous peoples of all the lands that we are situated on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of these lands, the ancestral and unceded territory of all the Inuit, Métis, and First Nations people all across Canada that call this nation home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Any information that is provided in this webinar should not be considered specific medical advice and is not intended as a substitute for medical professional help, guidance, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you have regarding your medical care. Today, we will be sharing valuable information on menopause management and treatment options from our expert speakers and individuals sharing their lived experiences. I would now like to introduce our panelists for today's session. Dr. Shafina Premji is a passionate women's health advocate and a menopause specialist in Calgary, Alberta, with a fellowship designation with the Canadian College of Family Physicians and in Women's Health. She holds a Menopause Society certification since 2015 and is the founder and medical director of 3 medical clinics. She serves on the board of directors of the Canadian Menopause Society and the medical advisory board of the Menopause Foundation of Canada, and advocates for menopausal women across the country. We are also joined by 2 members of our community who will be sharing their lived experiences with us today. Sharon Somani is born and raised in Calgary and is a passionate entrepreneur who co-owns Chef's Fury Kitchen with her sister, specializing in Indian and Thai curries. Beyond business, she has a love for travel, and her journey through perimenopause has been one of self-advocacy and learning. Shalina Farid Qasim is a professional accountant with over 35 years of oil and gas with leadership experience. Currently, she is semi-retired and will be sharing her reflections on her journey with menopause. Thank you for taking the time to be here with us today. Over to you, Dr. Premji.
Thank you, Maheen, and Yalimadat to everyone. It's a pleasure to welcome you to the second part of this webinar on menopause. In the first webinar, we really highlighted the symptoms of menopause, what menopause is, as well as understanding the history of hormone therapy over the last 20 to 30 years. We also discussed how to prepare for your healthcare provider's appointment in terms of a symptom tracker. We also reviewed the importance of breast, bone, and heart health risk assessment, because as a healthcare provider, when we talk about treatment options, we really want to have a good understanding of your individual symptoms as well as your individual risk for hormone therapy, and to select a treatment option that's best suited for you based on your symptoms, your risk factors, as well as your preferences. So in this next webinar, we're going to spend 30 minutes together where I'm going to offer you many treatment options that are currently available in Canada, both in terms of hormone therapy prescriptions, as well as options for patients who may not be able to use hormone therapy or may who choose not to use hormone therapy. So let's begin. So as a beginning, I would just like to acknowledge that I have some disclosures. I do receive honoraria from various pharmaceutical companies, but I do not believe that there is any conflict for today's presentation. So as I mentioned, the objectives of this webinar today is to really understand hormone therapy, what options are available in Canada, counseling pearls as you may consider any hormone therapy products for yourself, and what hormone therapy does for your symptoms and what hormone therapy does not do. Because there's a lot of misinformation about hormone therapy being a form of primary prevention or for anti-aging, and I really wanted to ensure that we highlight and talk about that today. In addition, for patients who have contraindications or who cannot use hormone therapy, we'll talk about non-prescription, non-hormonal therapies, as well as alternative therapies as well. So let's begin. Once I have met with a patient, understand her symptoms, and do a risk assessment in terms of her breast health, her heart health, and her bone health, here are some of the things that I consider as I'm selecting a treatment plan for her. The first thing is, does she have any contraindications, which I will talk to you about in one moment. It's important for me to know how old you are, because how I treat a 40-year-old patient who's still getting periods versus somebody in her late 50s versus somebody who's in her 60s may be very different. It's important for me to understand, are you in that early perimenopause, late perimenopause transition, which I defined in the first webinar, or are you actually already in menopause? If you are a woman who's perimenopausal, there still may be a risk of pregnancy. So I also want to keep that in mind as I'm selecting a hormone therapy option for you. And as I mentioned, we look at your heart disease risk and your breast cancer risk, because various forms of hormone therapy may or may not increase or decrease your risk. So it's important for me to understand that. And finally, we want to find a regimen that's easy for you to comply with and that you're going to be most likely to use regularly. I take into account patients' individual preferences. And then we also want to understand whether or not your hormone therapy prescription is actually covered through your insurance or if you are able to afford it out of pocket. So when we initially look at the contraindications to hormone therapy, here is what the Canadian Menopause Society guidelines state. Specifically for estrogen, any abnormal vaginal bleeding. So if you present to your healthcare provider and you're having a lot of variability in the length and flow of your bleeding, or if you are a woman in menopause who's now started having bleeding after 12 months, this is abnormal. This requires investigations. You may need a pelvic ultrasound, and you may also need an endometrial biopsy. So before starting or initiating hormone therapy, we really need to understand what's happening with your bleeding profile. If you have a history or current history of breast cancer, this is a contraindication to systemic hormone therapy. You may potentially be able to use vaginal estrogen, which is beyond the scope of today's presentation, but it is a possibility for your genitourinary symptoms. If you have any other estrogen-dependent cancer, there may be contraindications. If you have had a heart attack or stroke, this is considered a contraindication to hormone therapy, specifically estrogen. If you've had a blood clot, either in your lung, which is called a pulmonary embolism, or a blood clot in your leg, which we call a DVT, deep vein thrombosis, it is on the guidelines as a contraindication. However, newer data and information in the literature does demonstrate that there are some forms of hormone therapy, specifically transdermal estrogens, that you may be able to use in collaboration with a hematologist or a thrombosis specialist. If you have a history of stroke, if you have a known clotting disorder, any active liver disease, or of course, if they're a risk of pregnancy. In terms of the contraindications for progesterone, there's only two. One is abnormal vaginal bleeding, as mentioned, or a history of breast cancer. Beyond that, most patients are able to access hormone therapy if they are under the age of 60 or within 10 years of their final period. So once I've determined you don't have any contraindications, I then use a system to help me understand whether you are a patient in a low risk, intermediate risk, or high risk category. The high risk category we've already addressed in the previous slide. These are patients who we really want to avoid hormone therapy for because of the high risk of abnormal and a high risk of adverse events. It's the low and intermediate risk patients that we want to consider. So if you are recently menopausal, if you have a normal BMI, normal blood pressure, you're physically active, your Framingham risk score is low, and you have a low risk for breast cancer based on a recent mammogram and breast density, then most forms of hormone therapy would be considered safe for you. And in the next few slides, I will talk about the various Health Canada approved products that we have. And if you are an intermediate risk patient, that means that you might have one of these conditions. That doesn't mean you cannot use hormone therapy. It means that we have special regimens and formulations that might be safer for you. So in the top few of these lists, diabetes, smoking, high blood pressure, obesity, if you are limited in your mobility, if you have an autoimmune condition, say Crohn's disease or lupus, for example, if you have high cholesterol or metabolic syndrome, or if you have an elevated Framingham risk score, oral estrogen therapy may be more risky for you because it does go through the liver. And because it goes through the liver, it increases risk of clot. And we want to minimize risk of clot on hormone therapy. So the way to mitigate that is by using a form of estrogen, which is transdermal. Transdermal meaning that it is applied either to your skin via a gel or a patch. So you would want to avoid oral estrogen, but a transdermal estrogen in the form of a gel or a patch would be considered safe for you. And if you have an increased risk of breast cancer, what that means is that you have very dense breasts, either that breast density C or D. And we have a couple of products, which I'll highlight in the next coming slides, that actually are ones that we would recommend because they either are neutral to breast proliferation or they decrease breast proliferation and may actually be protective in terms of breast cancer risk while still managing many of your menopausal symptoms. So what are the benefits of hormone therapy? Well, let's go through this together. The majority of patients who take menopausal hormone therapy have a 75 to 90% reduction in moderate to severe hot flushes. Now, in my case, in my real life experience with patients, the majority of patients actually tell me their hot flushes have completely dissipated. But I want to be realistic with expectations, and sometimes it depends on the dose. You may start at a lower dose of estrogen, and you may need to make a little bit of tweaking here and there to optimize the dose to ensure that those hot flushes are a lot rarer or have completely dissipated. But we can reassure patients that vasomotor symptoms are very well responding to hormone therapy. If your hot flushes and night sweats have improved, this also have a direct impact on your sleep quality. Patients report that they're sleeping better, and that means that they're waking up more refreshed, they have less cognitive brain fog, and their mood and mental health will also be improved. So there's a direct impact on treating hot flushes to a woman's quality of life in terms of her sleep function and quality, as well as her mental health. Vasomotor symptoms are only part of the treatment paradigm. Women also may report improvements in palpitations I've seen, improvements in joint pains, improvements in migraines as well. Now, keep in mind, these are not primary indications for hormone therapy, but sometimes patients who use hormone therapy for their bothersome hot flushes also will acknowledge improvements in other paradigms and symptoms as well. Systemic hormone therapy may also treat the genitourinary syndrome of menopause, as I mentioned in the first presentation, specifically those vaginal symptoms, the urinary symptoms, as well as your sexual function. And if patients are still not optimally treated, we may want to also consider adding vaginal estrogen, which is beyond the scope of today's webinar, but just wanted to highlight that. And hormone therapy also does protect your bone health. In Canada, it is not a primary indication for osteoporosis prevention, but in the USA, hormone therapy is specifically and is indicated for the prevention of osteoporosis. There's also a big question patients ask about how long they can use hormone therapy for. And the answer is that we don't really have an end date. Every year that a patient is on hormone therapy, it's important that we do a risk assessment where we look at what are the benefits of continuation versus what are the risks of continuation. And it's an individualized discussion between a patient and a healthcare provider about how long to use hormone therapy and also what dose of hormone therapy and regimen she should be using. But in particular, for the majority of women who are under the age of 60 or within 10 years of her final period, menopausal hormone therapy is primarily of benefit, provided she doesn't have any contraindications. What are the risks of hormone therapy? It's important for us to consider this as well. As I mentioned in the first webinar, there is a minimally increased risk of breast cancer, and this is primarily for women who are using both estrogen and progesterone. If a woman has had a hysterectomy and is on estrogen alone, and in particular Premarin, we actually have good data from the Women's Health Initiative that it decreases breast cancer risk. So the risk of breast cancer right now is really for the women who are on estrogen and progesterone in combination, but the risk is nominal. We're talking 1 to 2 patients per 1,000 patients after 5 years of use for micronized progesterone with an estrogen. So it's quite low, but it is still important to keep in mind. The form of progestin or progesterone that you use increases that risk. So that is an important conversation that you have to have with your family doctor or your healthcare provider. As I mentioned, if you are using an oral form of estrogen, it does increase clot risk because it does bypass and is metabolized by the liver. But if you use a transdermal estrogen, it bypasses the liver, and so that clot risk is decreased. As I mentioned, for women under 60, menopausal hormone therapy in general is beneficial. And there's always this question of what happens when I stop my hormone therapy. And we really don't know what happens. Sometimes it's important that we don't just stop cold turkey, but that we actually consider going through a weaning phase where you may very gradually decrease the dose to the lowest dose that you need to manage symptoms. And if your symptoms don't return, then it would be very appropriate to discontinue. But again, that is requiring a regular support with your healthcare provider. And as I mentioned at the bottom, hormone therapy is not indicated for hair loss, for anti-aging, for primary prevention of dementia or heart disease, and it does not do anything in terms of weight loss or weight gain. The only time hormone therapy is indicated for primary prevention is for women who are under the age of 45 in early menopause or under the age of 40 in premature menopause who need hormone therapy until the age of 51 for the prevention of long-term consequences such as dementia, heart disease, and osteoporosis. Let's now move into the actual hormone therapy regimens. So I wanted to highlight to you here that we actually make 4 different types of estrogens in our body: estrone, estradiol, estriol, and estetrol. And the most potent form of estrogen that we make comes from the ovaries, and that's called estradiol. So when you look at a bioidentical hormone, what that really means is that it's still a product that is made in a lab. However, the molecular structure of that product is identical to what our body makes, and that in particular is estradiol. Now, it doesn't mean that estradiol is better than any other form of estrogen, such as Premarin, which is another form of oral estrogen. It just helps you understand that that particular product has the same molecular structure, but all forms of estrogen that has been approved by Health Canada are equivalent in terms of efficacy and safety. And then we also make progesterone as well. That comes from the ovaries, from the adrenal glands. It can come from the placenta when you're pregnant, and there is also some progesterone also made in the brain. So as I mentioned, bioidentical primarily means that that hormone that is still made in a lab that is prescribed to a patient is in identical molecular structure to what we naturally produce, but it's a marketing term. And why I say it's a marketing term is because as patients, it is marketed to us as being more safe or more natural. But the reality is that all hormone therapy products which are approved by Health Canada as I mentioned, are safe and efficacious. And so you don't necessarily need to use a bioidentical, but it is something that is an option for you if that is the best option for you based on your assessment with your healthcare provider. Why there's a concern with compounded hormones and those that are not approved by Health Canada is that every individual pharmacy makes that particular compounded product a little bit differently. So we cannot predict the actual amount of active ingredient. We cannot predict the safety of the product. We don't really have any quality control. So it's important that we consider that as part of our consideration when accepting a hormone therapy product. Whereas hormone therapies, which are approved by Health Canada that are not compounded, have gone through rigorous trials, clinical trials to confirm safety and efficacy, and that we know that the dose in that product is exactly what there is. There's also the concern around progesterone creams. Progesterone in hormone therapy is primarily there for women who have a uterus to protect your uterus from endometrial cancer. And unfortunately, progesterone creams are not well absorbed through the skin. So if you're using a compounded progesterone cream, we don't have any particular way of determining if it's an actual appropriate amount to provide that protection to the uterus. So the recommendation from all menopause societies across the world is that you do use a product which is approved by your individual country. And in Canada, that would be Health Canada. So here are the various hormone therapy regimens which are approved in Canada. So in particular, let's talk about the progestogen. So this is either progesterone, micronized progesterone, or a progestin, which is a synthetic progestin. So micronized progesterone is on the bottom here. It's a round tablet that patients generally take at nighttime because it has a metabolite that actually metabolizes into allopregnanolone in the brain. That works on the GABA receptor in the brain, and that provides a calming, relaxing, sedating effect, which is why micronized progesterone is recommended to be taken at nighttime. It can be taken every day, and that's primarily for women in menopause, or it can be taken cyclically. Cyclically meaning for 14 days of the month for women who are still menstruating. And that's because if you don't take it cyclically, there's a higher chance of breakthrough bleeding on the use of progesterone. There's also a couple of progestins, Provera and Norlutate, and these products are progestins, again, oral tablets with various dosages. And then we also have an off-label use of the Mirena IUD. So the Mirena IUD is a small T-shaped device that's placed in the uterus that many women know as a form of contraception. In Canada, it's been approved to prevent pregnancy for up to 8 years. It's a form of progestin. It has progesterone in it called levonorgestrel, and it's used to protect the uterus as part of a progestogen with hormone therapy. So how I explain this to patients is that if you are using some form of estrogen as part of your hormone therapy regimen, that estrogen is beginning to thicken the lining of the uterus. So it provides the relief of many of your symptoms, but at the same time, it's also thickening the uterine lining. And that becomes dangerous when that lining becomes too thick because it increases the risk for cancer to the uterus. So I tell patients that estrogen is like a fertilizer to the lawn or like the uterine lining. And the Mirena IUD is like a lawnmower. It controls the lining of the uterus to preventing uterine cancer. So the Mirena IUD is a local form of progestin in the uterus to protect that lining. The other formulations are oral tablets. When you're using a Mirena IUD specifically in the combination of hormone therapy, as I mentioned, it's approved for up to 8 years for birth control, but as a form of hormone therapy, we only have safety data for up to 5 years. So your Mirena IUD can be used with estrogen for up to 5 years at this current point. Here is a list of systemic hormone therapy products. So systemic combined products means that there is a form of estrogen as well as a form of progesterone in an individual tablet or an individual patch. So at the top, you can see here, we have a couple of 3 oral tablets. And in the middle, we have a Stellis patch, which has got both estradiol and progesterone. And at the bottom, there's a couple of new products that have been approved, by Health Canada called Duaviv and Tibella. And these are the two oral products that I mentioned that actually have protection to the breast proliferation. So if you are a woman who has dense breast tissue and are worried about breast cancer risk, these are two products that you may want to consider as a form of hormone therapy, because not only will it treat your menopausal symptoms, it also will not increase your risk of breast cancer. So here is the list of approved estrogen products in Canada. And as you can see here, we have a couple of oral products, which are estradiol estrase or Premarin. And then, as I mentioned, for patients who may have any of the cardiovascular risk, like high blood pressure, diabetes, high cholesterol, smoking history, you would want to use a transdermal estrogen. And these are the options available. We have a couple of gel options and we have a few patch options with the appropriate dosages. And all of these tables are available on the mq6.ca website if you would like to access them again in the future. So what if you are a woman who may not want hormone therapy, or you may have side effects of hormone therapy, or you have contraindications to hormone therapy? So for example, you're a breast cancer survivor, or maybe you're just waiting to see a specialist and you don't know what to do, and you're really bothered by your vasomotor symptoms. What options can you consider to manage your symptoms? So as I mentioned, these are the patients who may not want to use hormone therapy. What options do we have available to you? So the Menopause Society in 2023 listed what they recommend in terms of guidelines for non-hormonal therapies to manage hot flushes and night sweats. And again, they broke this down into green light recommendations, yellow light recommendations, and things that we don't recommend in the red light because we don't have enough data in the literature and science to be able to tell us that it actually is effective in treating symptoms. So we'll go through these individually. In terms of green light options, here are the non-hormonal therapy products that we currently have in Canada. So what this means is that the majority of these products are approved by Health Canada, but they're off-label, meaning that they have been approved for a different indication, but we have now understood and have found some data that supports that it does actually reduce hot flush frequency modestly by about 50 to 60%. So at the top, we have the SSRIs and SNRIs. These are forms of antidepressants with their appropriate dosages. We have gabapentin, which has been approved by Health Canada to treat epilepsy as well as nerve pain with the appropriate dosages. Gabapentin generally is taken at nighttime to begin. It does have a sedating effect, and as you increase the dose, there are more side effects. So you want to start low and increase it as supported with your healthcare provider up to 3 times a day. And oxybutynin is a bladder drug. So this particular drug has been approved by Health Canada to treat overactive bladder, but in particular, it has also been shown to decrease sweating for patients. And so there may be a role in using this. However, it does have side effects in that it can cause dry eyes and dry mouth and can have an effect on cognitive function for elderly patients. So we do want to be cognizant of that. And finally, I want to highlight fezolinetant. This is a brand new product that has just been approved by Health Canada in the last 2 to 3 months and should be in the pharmacies momentarily. And what is brilliant about this medication is that we actually now understand the pathophysiology in the brain of how hot flushes occur. So as women, up until this point, we have never really understood how hot flushes happen in the brain. But now that we understand the mechanism, we can actually create a product to target that mechanism to prevent hot flushes from occurring. And so again, just highlighting here that there are a couple of other products that were previously on the recommended list, which has no longer been recommended. And that's in particular pregabalin or clonidine. And again, if you are interested in these products, you may want to talk about this list of products with your healthcare provider. But I really just wanted to highlight that there are many options that you can consider with your doctor. What about lifestyle interventions? So what about cooling techniques? What about avoiding hot drinks or maybe avoiding spicy foods? But what about exercise and yoga? What about any individual dietary changes like the Mediterranean diet or intermittent fasting? Do these actually have a direct implication to your hot flush frequency? And current data does not support that, although there is some good evidence from the literature that if a patient considers weight loss, there may be some reduction in hot flush frequency and severity. Many patients also consider supplements. Now, with respect to supplements and herbal products, often patients are waiting for a long period of time to see their healthcare provider. And I know many women talk to one another and maybe alternative practitioners who may be recommending many of these products. And so there's a list of various things that I've heard from patients that they may have attempted to use specifically to treat their hot flushes. And when we actually look at the data, the data on these products are based on very small clinical trials. The patients in these trials have a very small sample size and they're not followed for a long period of time. And the majority of these patients actually have quite mild symptoms. So up until this point and until today, there is really no recommendation that we recommend any of these supplements or herbal products to patients because, again, we don't have any true efficacy to confirm that they work effectively and or that they're safe. When products that are natural food products are approved by Health Canada, they don't need to go through any large, randomized, rigorous testing criteria, and therefore they are approved without really good evidence. Until today, we as a Canadian Menopause Society and all menopause societies do not recommend specifically using any herbal supplements to treat your menopausal hot flushes. There is actually excellent evidence for cognitive behavior therapy and clinical hypnosis. But what about mindfulness-based interventions? What about paced respiration or relaxation techniques, which when you're experiencing that hot flush and that palpitations, does it help to actually slow down your breathing? Does it help to do some meditation? What does it actually do to your hot flush? And when we look at the guidelines and what the current literature says, it says that cognitive behavior therapy and hypnosis actually have excellent evidence to improve hot flushes. So understanding how your brain and the behaviors that come with the experience of a hot flush can really help a woman cope with that hot flush more effectively. The challenge with this is that it's very hard to access healthcare providers or practitioners that can provide cognitive behavior therapy or hypnosis to specifically treat hot flushes. But if there is somebody in your jurisdiction or in your city that could offer that to you, these are very well recognized as effective treatments. I want to highlight fezolinetant to you because this is an area and a specific non-hormonal therapy that is the first kind in Canada that has been specifically approved for treating hot flushes. And I want to help you understand specifically how this product works. So if we go into the brain, and in particular in the brain, we're looking at the hypothalamus. And inside the hypothalamus, we have many neurons, and neurons are involved in regulating all the functions of our brain. And in particular, I want to highlight a specific group of neurons called the KNDy neurons. KNDy standing for kisspeptin, neurokinin B, and dynorphin. And I like the catchy name KNDy because it's easy to remember. If you can remember one thing to remember is that these KNDy neurons control our thermostat in our brains, the thermoregulatory centers of our body. So when we feel cold, it tells us to shiver and vasoconstrict and close down our blood vessels. And when we feel hot, we want to sweat and we want to dilate our blood vessels to cope with that feeling of warmth. And so the KNDy neurons are in perfect balance to be able to allow us to control that. On these KNDy neurons, there are two special receptors that you need to be aware of. One is the estrogen receptor in blue, and one is the NK3 receptor on the left and right. So these receptors are expressed on these KNDy neurons, and these receptors are involved in keeping those KNDy neurons in balance. So for a woman who has estrogen present in her body, who's in that reproductive years, it provides an inhibitory effect on the KNDy neuron, whereas the NK3 receptor binding to a molecule called NKB provides excitation on that neuron. So when we have excitation signals and inhibitory signals at the same time, these KNDy neurons are in balance. However, when a woman enters into menopause or in that late perimenopause transition where those estrogen levels begin to drop, and there is an absence of the inhibitory effect of estrogen on the KNDy neuron, these KNDy neurons begin to swell and hypertrophy. And the swelling and the hypertrophy of these KNDy neurons is what causes a dysregulation of that thermoregulatory center of our brain. And that's when we as women start to experience hot flushes. So in order to combat this effect, we have a couple of options. Option number one is we would bring estrogen back and try to control that effect. Or if a woman cannot use estrogen, the other option is introducing an NK3 receptor antagonist, which is on this picture in blue. And so what that does is it prevents it prevents the NKB molecule from attaching to the NK3 receptor. And now that KNDy neuron is also not able to swell, and we are now able to control those hot flushes. So it's brilliant that we now understand the pathophysiology of how hot flushes occur, and we now have a product approved by Health Canada specifically to target those receptors on that KNDy neuron to manage hot flushes. And from what I hear from colleagues in the US as well as Europe, where this product is already approved and being used, this can be very effective. And in fact, within 1 week, patients report a significant improvement in hot flush frequency. And so again, this slide just highlights exactly the function of fezolinetant, which is that NK3 receptor antagonist, which is managing and controlling those hot flushes and helping to restore the thermoregulatory balance in the brain. So in terms of the product monograph, which is what was Health Canada approved, it's a single oral tablet taken once per day. There are a couple of known contraindications, which are listed here. But for the majority of patients who do not have any contraindications, fezolinetant may be a great option if you may not want to use hormone therapy or may choose not to use hormone therapy or have any contraindications. And finally, it's important for us to remember that lifestyle intervention and preventative healthcare is always important. As a healthcare provider, I do encourage patients to optimize their sleep. I see sleep as a vital sign for women. And if you do have any risk factors for sleep apnea, I highly recommend that you have a sleep study done. If you have chronic insomnia, the recommendations are that cognitive behavior therapy for insomnia is considered standard of care, even more so than sleeping medications. So I would also recommend that you optimize your sleep that way. In terms of healthy diet, there's a lot of research now highlighting the importance of adequate protein intake as well as fiber consumption in your daily meals. And finally, to maintain your skeletal health, function, and muscle health as well, we do recommend strength training at least 2 to 3 times a week to ensure ongoing independence and preventing a long-term risk of falls. So in conclusion, I would hope that over the last 2 webinars, I have been able to provide you with knowledge, tools, and the ability to feel empowered through your menopause journey. I know that it can feel very lonely. Many patients do tell me that their family doctor or their healthcare provider is not able to support them. And that is primarily because of a lack of education in our healthcare system, specifically for medical schools and residency programs. However, we are working hard to correct that challenge, and we are offering a lot of continuing medical education for colleagues across the country. It's important that you also speak out about your symptoms in the workplace so that they can support you in managing your symptoms at work. And remember that one size does not fit all. Every individual patient has her own individual story and experience, and it's an honor and a privilege as a menopause specialist to be able to support women, listen to them, validate their symptoms, and really come up with an individualized, comprehensive plan that treats her symptoms based on evidence, based on science, and based on guidelines. And so with that, I really want to thank you all for joining me over the last two webinars, and I look forward to continuing to support patients. And with that, I'm going to hand it over to Maheen. Thank you so much.
Thank you so much, Dr. Premji, for such an informative presentation. I will now be inviting Sharon Somani and Shalina Kassim to share their lived experiences. Thank you so much for joining us today, Sharon and Shalina, and taking the time to share your experiences. Let's start with Sharon. Over to you, Sharon.
Hi, everyone. Sharon Somani here from Calgary. I'm here to talk about my lived experience with perimenopause. I'm 49 years old. It started about 5 years ago. It was a cold, freezing cold, wintry day, -30 outside. And I was driving home from work. I was all bundled up and I had my heat on high. When all of a sudden this heat rushed through me, it was rushing through my body and my heart was racing like crazy. And I was like, what is going on? Am I having a heart attack? I even thought like maybe I need to pull over. I don't know what's going on. It was quite frightening. But anyways, I opened up my windows and cold air was rushing in and I still, had this heat rushing through me and my heart was just racing like crazy. So anyways, about 15 minutes later, it passed. And it was scary and I just chalked it up to like a lot of stress or too much caffeine that day and that was it. Nothing really happened for a while, but then about 3 years ago I felt a shift in my moods. I was feeling like just not like myself, really irritated and frustrated, and this just wasn't how I was. And then about a year ago, the hot flashes came back. But now it was throughout the day and it was keeping me up at night. It was awful. So I went and made an appointment with my family doctor and chatted with her. And, like many family doctors, she wasn't going through perimenopause or didn't really suffer through it. And so she decided to put me on antidepressants. And she just said, like stay off the electronics an hour before bed and listen to some calming sounds and hopefully that'll help. I didn't feel depressed, but I just wanted relief and I thought why not give it a shot? So I tried it out and it worked a little bit, but I was still having hot flashes. I wasn't sleeping at night. I just wasn't feeling great overall. Um, and then that's when I decided to go back to my doctor and I asked her, I had heard a lot of things about Dr. Shafina Premji and all the work she did with women and women's health. And so I asked my doctor to refer me to Dr. Premji, and she was so amazing. She, understood my symptoms. She listened to me. She sent me for blood tests, and she listened to like my um, family history, and then decided that everything was all good, and I should start a low dose of estrogen and progesterone. So it's been about 5 months since I've been on the estrogen and progesterone, and I feel amazing. Like I no longer have hot flashes, my moods are great. I'm so glad I did that and, advocated for myself and didn't just stay on antidepressants and hope everything would go away. So what I suggest to anyone who's going through perimenopause, it's nothing to be ashamed about. All women go through it. We all have different symptoms and there's help out there. So go out and get it if it means, going to see someone who listens or whatever it takes. Do it because it really helped me. And that's it. Thank you.
Thank you so much for sharing your experience, Sharon. Now over to you, Shalina.
Hi, I'm Shalina Castle and I'm from Calgary. I have been on hormones for longer than the two other candidates that we have simply because of my age. I started when I was 48 years old, and my experience was not normal because you go into perimenopause gradually, and I found out that my cycle just stopped all of a sudden, and the vaginal dryness was so bad that I couldn't take it anymore. And I went and I saw my doctor, and I was fortunate to have a doctor that I'd been seeing for 20 years, and she was a few years older than me. And she said, "Welcome to menopause and perimenopause." And she said, "You know, I would love to help you out." She was one of the few doctors that was ever into it at that time. She said to me, "I will do this, but you need to do your own research first." She guided me. She asked me to read a book or two, asked me to look at YouTube videos of some doctors that were talking about it. I did a lot of research before I went back to her, and then we discussed it. And she said, "Okay, I think you know enough now that we can put you on hormones." So she basically was doing bioidentical hormones at that time because the pharmaceuticals, we're talking about 2011, and it wasn't very common at that time. People didn't talk about anything to do with menopause or the symptoms. They just thought that this was normal life and it was part of aging for women. That's how sad it was. And she put me on bioidentical hormones, and instantaneously, like when you go on hormones, like you've heard before, it doesn't take long. It's within days you start to feel better. I felt good about myself. The other symptoms that I didn't think were related, like my mood swings and my brain fog and fatigue, that all went away. It was like magic potions that I was getting, and I was on hormones for the longest time. And like about 3 years ago, she retired, and she told me, "I give you 6 months to look for a doctor." And I thought, "Oh my God, where am I going to go now?" Because I was thinking of the time when nobody talked about it, but sure enough, it was more common now. People were talking about it. And thanks to my daughter, she came to me and she said, "Mom, you need to go see Dr. Shafina Premji," because Dr. Shafina Premji's sister, Dr. Shafina Premji's sister is my daughter's friend. And so she was following Dr. Shafina a lot. And she said she talks about menopause a lot. She's on the board. "Mom, you need to go see her." So I went to my own doctor and I said, "I want to be referred." So that's the first thing. You need to be your own advocate. You need to say what you want for yourself, because these doctors are not going to talk about it all the time. They're not going to recognize what you're going through. I had to wait 6 months to see Dr. Shafina Premji, but sure enough, I went to see her, and I took all the bioidentical hormones. And the first thing they said, I don't do bioidentical, but are you open to trying what I have for prescriptions?" And I said, "Definitely." I saw her about a year and a half ago. She put me on progesterone and estrogen and vaginal inserts, and I felt like normal again. And I actually felt better, because I don't know if bioidentical hormones are regulated, if I can say that now. I never believed in that before, but I agree with Dr. Shafina. They're not regulated. Dr. Shafina Premji was awesome. She is such a good listener, and she's so compassionate. She listened to all my concerns. She also added testosterone to it, because I was telling her about other issues that I was having, like mood swings, or even exertion or energy or whatever. She added a little bit of it, kept sending me for blood tests to monitor if my dosage was right. And I've been on HRT for the longest time, and it has really improved my quality of life. When you have improved quality of life, you don't have brain fogs. I was able to concentrate during the transition into my career, into my management positions that I was holding at that time. I just couldn't afford to have these brain fogs, and it helped me immensely with everything. Overall, it helped me take care of myself better. I wanted to be fitter. I exercise every day. At my age, I'm over 60. I'm 61 right now, and I run 5 to 6 kilometers on a good day. And some women would say, "How do you do that?" Everybody can do that. You just have to look after yourself. You have to be you have to be aware of what your body is telling you, what your body is lacking, or if something is wrong, you need to discuss it openly. I'm on managed levels of estrogen, progesterone, and testosterone, and vaginal inserts to eliminate all of those symptoms. I am so thankful for all of these medications that I'm getting, because it has improved my quality of life. It has improved my relationships in my life. It has helped me in my career throughout my lifetime. It continues to protect my health when I'm aging, and it's going to safeguard my bones, my heart, leave alone. I could get diabetes because I'm not eating well if I'm not feeling well. I'm not exercising if I'm not feeling well. High blood pressure, all of those things are related to your well being. In the end, I'd like to say everyone here that you need to advocate for yourself. It's not just simple to go to a doctor and say, "This is what I'm feeling." You have to do some research of your own too, to know what you're talking about. And what is this when you list all your symptoms and go to your doctor and say, "No, antidepressants aren't going to work. This isn't just a band-aid that you want to put on one thing. These are the things that I'm feeling, and I need to see a specialist or a doctor that is specialized in hormone therapy or recognizes what I'm going through." If I'm able to help women or anyone thinking about this more further than what their symptoms are as to how they can help themselves, this is all I hope to achieve. I would like to thank you for letting me express my thoughts. I'm hoping that this was helpful to everyone. And of all, I'd like to thank my daughter for finding Dr. Shafina for me. And I'd like to thank Dr. Shafina for taking such good care of me. Thank you. Yali Madan.
Thank you so much for sharing your experience, Shalina. This brings us to the end of today's session. I would like to thank Dr. Premji, Sharon Somani, and Shalina Kasim for the excellent information provided to us today to help us with navigation through menopause. Please visit iicanada.org for up-to-date information on resources and information on the 5 to Thrive program, articles on health and well-being, and additional webinars. If you require individualized supports or resources regarding your health, please contact the Health Navigation Service through the Access line. Your feedback is very valuable to us and helps us develop and share further programming. Please take a few moments to complete the evaluation survey found in the description of this video. Thank you to you, our audience, for joining us today. Till next time, Ya Ali Madad.